Pfizer actually makes Depo Vera and Depo Pro Vera, and nobody there could tell me why they've got two different named products with exactly the same ingredients. It's just, it is what it is. It's really weird that it is the same company. The product information, when you print them off, the product information is ever so slightly different, but and that's only with the layout. The content's still the same. And I couldn't find a photo of Depo Vera anywhere on the internet. And the stock that we have here is the Depo Pro Vera one. What's the correct ingredient of the Depo, do you think? Is it A, B, or C? Any takers? How many people say yes if you think it's A? Say yes if you think it's B. And yes if you think it's C.
Think C.
So
I think it's B too.
Okay, so the actual correct ingredient is that C, medroxyprogesterone acetate. But that's not very interesting, is it? It's 150 milligrams and it comes in 1 ml containers.
Just a question from the chat. For the Pro Vera and the other one you mentioned as well, sorry.
The Pro Vera and Vera, yep.
Yeah. Are they both sold for the same price as well?
Oh, I think so. I actually haven't looked that up, so I can get back to you on that one. But being the same company, I think, and maybe just in WA, they only, like Pfizer, only give us the Depo Pro Vera. I'm not too sure what's actually obtainable, but it is on a script. So I guess if they didn't have Vera, you can confidently use the Pro Vera. Which of the following is not a method of how the Depo Pro Vera or the Depo Vera works? What do we think? Any takers?
B.
I say B as well.
Perfect. Okay.
B.
Yep. So with the Depo Pro, I'll just call it Depo Pro Vera rather than the medroxyprogesterone acetate. Its main primary action is stopping ovulation. It does have an impact on the lining of the endometrium, which is the lining of the inside of the womb, so that if there was anything that did get fertilized, it would make it really difficult to implant into. But instead of creating a mucus plug in the fallopian tubes, it actually creates a mucus plug in the cervix, and sperm find it really hard to swim through that. With fertile mucus that goes from the vagina up through the cervix, it actually has little channels in it, and that helps the little sperm with their tails move up through the little columns. With the infertile mucus, that's the reaction from the progesterone part of things, it actually makes the mucus all mixed up, so there's not nice clean channels for it to migrate up through. There are some precautions before we give the Depo. Can anyone suggest any things that we need to be mindful of?
To check they're not pregnant.
Pregnant?
Yeah, we don't actually want to give it to anyone who is pregnant. So if we're starting out giving a first injection, it's a good idea to give it between day 1 and day 5 of their period. And as long as that bleeding is a normal routine type of bleeding pattern that they're experiencing. So if you do a pregnancy test, how soon can you do a pregnancy test after the person falling pregnant, do you think?
Do you remember, Jen?
Pretty darn early. I don't know.
Like a week?
We actually say to make sure that you're giving an accurate result to a wide group of people, a pregnancy test at 3 weeks or a urine pregnancy test at 3 weeks will be quite accurate. Before then, you could be having false negative results. So 3 weeks after an event that they're worried about, it will be an accurate test. If you do it too soon, maybe you haven't got enough hormones to show up yet. So 3 weeks.
Also, as well, the sperm can kind of hang around for a bit. So.
Yeah, the sperm can hang around for up to about 5 days in that little canal of the cervix. There's all sorts of little pockets that it can hang around in, and yeah, so it can hang around for quite a while.
That's really interesting because I did a pregnancy test on a lady and nothing showed up. It was all negative. But when we did the PCR, or when we did the blood, sorry, it showed up that she was pregnant, but none of my readings came up. So that was really, yeah.
So even with the blood test, where I used to work at another site, we used to even say it's a good idea to even wait 3 weeks for the blood test. The blood test will usually show up a little bit earlier than the urine test, but we sort of thought there wasn't too much difference between both of them. The blood test will show up a bit sooner, but just keep it in mind, you can't do it too soon after an event that they're worried about. We also need to be careful of allergies before we're giving the injection. And we also need to make sure that it's prescribed by a doctor. This can be a little bit tricky where you get some doctors who are happy to prescribe the Depo and give you repeats for it. Some doctors don't put the repeats on. So when we're checking our Communicare or whatever medical software that we're using, just be careful that you are giving a prescribed medication.
It's another thing to check as well to make sure that they've actually got a uterus still.
Yes, because I can't imagine why they would want a Depo if,
It can happen.
Really?
Yeah,
Interesting.
that's very, very good. We also need to check that it's correct timing. Oops. And also check for reproductive coercion risk. What do I mean by that?
The risk that someone's trying to get them pregnant, or that this isn't their choice, or
just be mindful that it is the person's choice that they're having it. So it could even be the clinician is pushing them into a Depo injection, but they don't really want it. So just double checking that they're happy to have the Depo. It is their choice, and they do understand the good things and the not so good things about it as well. So it could be the clinician, it could be a partner wanting them to be pregnant or not wanting them to be pregnant or whatever. And for anyone who is in that situation where they are being pushed into a pregnancy but they don't want to, the Depo seems to be one of the more discreet ones that they can have it, and you can't, like, the partner won't be able to find pills or won't be able to feel the rod in the arm or those sort of things. It's just if they were using it, they'd might have to pretend that they're getting periods so that the other person's not aware. But just being mindful of those sort of things. How was it given? So can anyone tell me?
Injection?
Yep. Whereabouts?
I think.
And anything else that we need to know about the injection? Okay.
Is there like ways for me to draw it up or anything like that?
Say that again.
I'm not sure of the specifics. I haven't given one myself, but are there specific ways you need to draw it up, or do you need to reformulate it or anything like that?
Yeah, no. So all you do is you just flip off the little purple top, wipe it with an alcohol wipe, let that dry, stick a 3 ml needle and syringe into the vial, draw it all up, but you do need to shake the vial first to make sure that all of the drug is dispersed into the aqueous solution. If you read the product information, it actually says to give it in the dorsogluteal area, so the upper outer quadrant of the buttock. It actually has a better slow release over the 3 months if it's given in that muscle. there's been studies done that have shown that people who are using a short needle, so say a 16 millimetre needle is too short, you need at least a 25 millimetre needle for a person with a normal BMI, and you probably need the 38 millimetre needle for people who are quite obese. Some studies have shown that most of the Depo injections are actually given subcutaneously, and they're not quite as effective as when they're given intramuscular. So if you do have a person who's particularly overweight, then the deltoid muscle is a good alternative, but the product information actually says put it in the gluteal muscle as first choice. That can be a little bit hard swapping people over if they're used, like if some other nurse or someone else has been giving it deltoid all the time. It can be hard to swap them over to going back to the gluteal. But ideally, if you're starting off a person, offer it in the gluteal muscle first. We also use a Z-track method for giving it as well. If you're giving it subcut, you have a greater risk of actually causing local skin reactions. So when you are drawing it up, you would use a drawing up needle, then swap over to an appropriate length needle. And instead of allowing the little bit of fluid to come out the end of that needle that's going to be used to actually give the injection, try not to have that little splash of fluid on the outside, because that can cause that topical skin reaction. Did that make sense?
Yes.
Yep. Okay, so shape it and deep Z-track. So you just pull the skin to the side, give it deep, and then release the needle, and the skin will go back over and cover over that little hole. If you are giving it as a deltoid injection because you can't talk the person into having a gluteal injection, this handout is from the immunisation handbook, but it does talk about avoiding shoulder injury with injections. And even though it's talking about vaccines, that absolutely can be used for deltoid IMI contraceptive injections, so everything that's on here. There's a lot of people who are giving the injection really too high up near the acromion process. It really has to be in the deltoid muscle area, so a bit lower than what some people are having. Just between you and me, I do know that I've had a injection, a flu injection that was way too high, and it felt like it was actually going into the joint, and that's quite dangerous. We don't want to be doing that. There's a few people who have needle anxiety, so they could be people who have had really nasty histories of having to have horrible injections really early on, like maybe the kiddies with rheumatic heart disease, maybe people with intellectual disabilities. There could be a whole host of reasons why they have a needle anxiety. So there's a few tips here for the patient. Has anyone got any particular tricks that they like to use?
I know myself, when I'm giving these sort of needles, I like to make sure they're chatting with someone throughout it. So they're not just sitting there silently thinking.
Actually, I don't have that on my list, but that's my number one. That's what I do all the time.
Yeah. But as well, I find for younger people, the phone's often really good. They can play a game or something while it's happening. And those sort of, those mindfulness things you've touched on there are good.
Yeah.
As someone who doesn't love a needle, I love a good just straight up look away tactic.
Yeah.
And also,
I've got one young boy. He likes to stand and lean over this table and do it. He reckon it's a lot easier for him. Yeah.
That in my old job, that's how we did it. We never laid a person down. They all stood up for it.
Yep.
It can be tempting for the needle phobic person to want to give the injection really fast. But if you think about a pimple popping and it splats everywhere, if you give a really fast injection, that all that fluid is trying to splat into the tissue really rapidly, which can be uncomfortable. So even though they're needle phobic, it's still better to do it over a slower process rather than a really quick, rapid one, because it is a whole mill.
I think as well, like knowing the patient. So some people will like to know when it's about to go in, but others, it's like, don't tell me when it's happening.
Yeah, just do it.
Yeah.
There's also for the rheumatic heart pain, especially for the kids. It's called a little bumblebee, and you stick it in the deep freeze, and then you can put it on for a few minutes. But if you give the needle, and it's sort of like make the kids think, oh, it's not going to hurt so much. We kind of like use that as well too with them.
And it has a little buzzing thing to it as it's giving. If you don't have the gizmos and gadgets, also when you're giving the injection, and if you tap next to the injection site with your other hand, some people find that that's a really good distraction as well. I've got this thing called Smiley Scope. That's actually probably better for the LA bicillin than it is for a quicker Depo injection. But if you have funds, and you want to buy a gizmo and gadget, that's actually quite useful for adults and children, but it probably takes more time to set it up and get it working than what you would have done with talking and just giving the injection. But still good.
Do you have a link to where you can buy it from? So just in case.
At the end of this, there are some resources.
Okay, thank you.
One of our maternal child health nurses bought us one just recently, and it's quite good. I've used it on a person with rheumatic heart disease. There are some people who must not use the contraceptive injection, and the best resource for working out who's eligible and who's not eligible is this Faculty of Sexual and Reproductive Health in the UK. So they call it the UK Medical Eligibility, or UK MEC summary table. I just Google it and I download a copy to have at my desk all the time. If you have a look at it, the first one says that it's a copper IUD. So CU IUD means a copper IUD. Then the next one says LNG IUS. So that's a Mirena or a Kylena intrauterine system. IMP means the implanon, but that actually stands for a contraceptive implant. DMPA is the depo-medroxyprogesterone acetate, so that's the Depo injection. POP is the progestogen-only pill, and CHC is the combined hormonal contraception. So just keeping those in mind, let's have a look at the next thing. So Billy is adamant she doesn't want children. She's 28 years of age. Her CST, or her cervical screening test, is up to date. She's reported mid-cycle spotting for the last 10 months. She's asymptomatic and she's in a long-term relationship. She smokes cigarettes and ganja daily. Do you think she would be a good candidate for the Depo? Are there any red flags in that little bit of history I've given you?
Spotting of the blood.
Yeah, she's spotting, and they're smoking cigarettes. I know there's some risk of that in progesterone. Okay,
so with the ganja, I think that the Depo is probably a really good idea if she doesn't want to be pregnant, because when she's potentially high, she might make choices that might not be absolutely safe choices for her. The smoking's not going to be a problem for the Depo, but definitely might be a consideration for anything with estrogen, so the combined oral pill. But the trick here is that cycle spotting, mid-cycle spotting, that needs to be looked at, because the Depo, if you give the Depo and she becomes amenorrheic or her periods stop, then she could have some sort of pathology going on that gets worse, but she's not showing any symptoms. So on that UK MEC, the orange circle is the one for the Depo. So any unexplained bleeding, even if she says it was ovulation bleed, you have to say to her, who diagnosed the ovulation bleed? Was it you or the doctor? If she says it was her, then she has to see a doctor for that mid-cycle bleeding. Have I lost anyone?
No, it all sounds good.
Okay.
That's good.
So Tamarind is 22. She's studying at university and has to go on field trips. She wants to avoid periods. Her BMI is 25.6. Would the Depo be a good idea for her, do we think?
And you reckon?
Yes.
Yeah, she's actually perfect, because if she's going out bush and if she's one of the lucky people to not get a period, then she won't have to worry about that hassle going bush, and her BMI is perfect. So the 1 means that she is at a really low risk. See how on the end of that table it's got a 2 and a 3? If she had a rating of 2, that's still safe, but a rating of 3 or 4 is too high, and they shouldn't use that form of contraception. That one on the far end is the one with any estrogen in it. So that's like the pill and what else has estrogen, and the vaginal ring that actually has the estrogen in it as well. All right, Maya's 47. She has been recently diagnosed with breast cancer. Can she have the contraceptive injection?
No.
Yep. So with this one, she's got breast cancer. So see number E down there, letter E down there, breast cancer, current breast cancer. She absolutely must not have the Depo. And even with her, if she had a past history of breast cancer, it's rated as 3, which means that she shouldn't have it. But there could be other things that she could consider for contraception instead. And just looking at that, it might be things like the copper IUD might be a good choice for her. Oops. Any questions on that? Okay. Peter has had complications from hepatitis C, and she has liver cirrhosis. Can she have the injection?
No. I said no.
So with Peter, we want to know a little bit more, because with the cirrhosis, so see that second little attachment down the bottom, if she's only got mild problems, but we can't make this determination, the doctor would have to, she probably can use the Depo. But if she's got really bad liver problems, then she shouldn't have the Depo. So that's a conversation with the doctor. Then we've got Teliana. She's 39 years of age, and she's got multiple health problems. Do you reckon she should have the Depo?
I think she should consult with her doctor first.
Yeah. Do we all agree?
Yeah, for sure.
Yeah. And that's exactly right. So we wouldn't worry about a BMI, but we would worry if she's got multiple risk factors and vascular disease and current ischemic heart disease or a stroke. We'd need to make sure that she was being safe and making sure that the doctor was keeping her safe. Okay, what about Justina, who's 32 and has migraines without aura?
She only got a migraine, I suppose.
Yeah, and that's perfect. So the only time we worry about migraines with or without aura is if they're on the combined hormonal pill or the combined hormonal vaginal ring. So in Justina's situation, she's absolutely fine to be on the Depo, but you can see that column over to the end, migraine with aura and being on anything with estrogen is a problem. Okay. How often do we give the Depo injections?
Is it 12 months?
I think you said every 3 months.
3 months?
Yep, so every 3 months. So the earliest we can give it. So if I was your patient and I said to you, oh, look, Danielle, I have, I'm starting, like, I really love the first 2.5 months of the injection, but now I'm starting to get a bit moody. I'm starting to get some spotting. I'd like my injection early. You're actually allowed to give it to me from 10 weeks from the last injection through to 13 weeks and 6 days. And within that time frame, it's considered on time. But if it's 14 weeks since my last injection and I've been sexually active, you'd have to check out with me if a pregnancy might have occurred. What do you think are some of the good things about the injection?
Only over 3 months.
Yeah. For most people, that's pretty easy. Like they can handle an injection every few months. Yep.
The possibility of periods.
Yeah.
Say that again.
Not taking any other medications like the pills or whatever.
Yep. Don't have to worry about anything on a daily basis.
Yep.
Possibility of not having periods.
Yes. Now, is that a good thing or a bad thing?
Depends on the person.
Yeah.
Some people in some cultures really worry about not having periods, but if we can do anything to mimic women 100 years ago, it's brilliant. So 100 years ago, we were either breastfeeding or pregnant most of our reproductive years, and maybe we got about 100 periods in our reproductive time frame. Modern woman probably gets something like 450 periods in our reproductive time because we're able to manipulate periods. So all we're doing is we're just losing blood, which means that we're just shedding iron, which means we're becoming anemic, which means we're becoming run down, which means we go to the doctor with all these health issues. And anything that we can do to mimic women 100 years ago is actually a good thing, and it's not actually doing any harm to us.
Interesting. I am an anthropologist, Elena, and I've never thought about that, but that is so true. It's so, and I'm a low iron, borderline anemic. Like I'm like an iron infusing woman post, and most women, like I can't show you data, but anecdotally, many women I know post having 2 or 3 children are all iron deficient, and we are all basically at our like blood loss end.
Yeah. There are cultures, like I've got friends who are Chinese, and they are horrified at the idea of not getting a period because in their culture, they say that when you bleed, you are releasing toxins. But we can't find any scientific proof about that. So in our Western culture world, what I said about the periods and mimicking what women did 100 years ago is fairly stock standard from Western world thinking.
That is so interesting.
I guess another good thing about them that you mentioned earlier was that if there is reproductive coercion, this is a nice subtle contraceptive that women can use.
Yeah, and it's just having that chat about them about ways that they might be able to mimic that they're having their period.
Yeah.
And that's the other thing. In some cultures, a woman, it's her duty to have sex when the husband or partner wants to, and maybe when they're getting their period, they're allowed to have time off. So if you were with a person from another culture, it might be worthwhile exploring those types of beliefs as well and see if it's a suitable thing for them. Some of the downsides is that it does cost some money for some people, that they are possibly needle phobic, that they do have possible side effects, and also some of the effects of the Depo. It has a temporary decrease in bone density effect on people. And it does delay, it's the only contraception that actually does delay return to fertility. So if I've been having Depo for a year or 2, maybe it'll take about 6 to 9 months for my fertility to return. But there are a few people who it will be even more advanced than that. It might take them about 18 months for their fertility to return. And so if I have anyone who's 30 plus, wanting the Depo, but also wanting kids down the track, I do warn them about that delay of fertility, because we know by 35 years of age, your fertility definitely reduces and it becomes harder to get pregnant. So we have to sort of factor all of that in. Has anyone else got anything that they would like to add? Okay. And so lastly, it's just about the recall and reminders. So it's really important that we do set reminders for people to recall them when they're due to come back. So some of the tools that we can use, you can use an obstetric tool wheel to work out when they're next due. If you just Google 12 weeks from today, that will give you a good idea. What I will often do is I'll actually recall them at 10 weeks to give them a 2-week leeway of being able to get back into the clinic. Because if I do it at 12 weeks and it takes them a couple of weeks to get their act together, they could then end up being delayed. And you can download perpetual calendars for people if you don't have good internet access or anything like that. Does anyone else use anything different? Oops.
At DAS, we have a recall system. Are you talking? So yeah, so we can go into it and we can put it on there, and then it automatically goes on for the recall. So when the drivers go out, they'll have them on there.
So it just like automatically sets
Oh,
that.
yep.
Nice, that's good. I don't know if Eleanor dropped out there.
I know.
Tracy from
We can't
DAS was
hear
just
you.
saying that they have it as an automatic reminder.
Great.
Yep.
Sorry I dropped out, everybody, but that was the end of the talk. I do have some resources, but I'll send an email to Veronica and that will have the PowerPoint presentation. So that was good. It happened at the last second.
I know. I'm sorry I missed it, but I'm going to watch your recording, Eleanor.
No worries. Thank you.
Easy. And yeah, I've recorded all of that here, so I'll send that through to V as well, so she'll be able to share that one around.
Oh, that's cool. And I guess, yeah, thanks so much for coming to do a bite with us, Eleanor. We'd love to have you back.
No
Yeah,
worries.
that was so
Anytime.
useful. Wow.
Yeah,
Yeah.
that's very useful. Yeah.
Great.
Yeah.
All right. Thank you, everybody.
See ya. Bye.